Hello, my name is Ashley Yacek, and I am a student pharmacist at Sullivan University College of Pharmacy. And today I'd like to talk with you about an article entitled Cardiovascular Safety of Celecoxib, Naproxen, or Ibuprofen for Arthritis. This article was published in 2016 in the New England Journal of Medicine. So the intent of the article was to investigate the cardiovascular safety of celecoxib, a COX-2 selective non-steroidal anti-inflammatory drug. And I found that particularly interesting because celecoxib, or NSAIDs as a class, remain one of the most widely prescribed classes of medications in use. So I thought that it had the potential to really make an impact on clinical practice, especially because it's used for conditions such as chronic joint pain, which affect millions of patients. So it's looking at the cardiovascular safety, which is actually something that has not been well studied, and that's not been well demonstrated in randomized controlled trials. So I thought it was the strength of the study that it was looking to fill in that gap in the literature. So as I said, NSAIDs are commonly used to manage chronic conditions, such as osteoarthritis and rheumatoid arthritis. Osteoarthritis in particular affects predominantly our older population, so those people are already at an increased risk of adverse drug effects, and they already have more comorbid conditions and they have a higher disease burden and things like that. So I think it was important to look at that condition, look at that indication for NSAIDs, and evaluate the safety in those patients. So NSAIDs reduce inflammation through the inhibition of the cyclooxygenase enzyme, or COX enzyme. There are actually two downstream that leads to decreased prostaglandin synthesis, and prostaglandins are inflammatory mediators that cause pain, so you get less inflammation and less pain through the inhibition of the COX enzyme. There are two isoforms of interest, COX-1 and COX-2. COX-2, the inhibition of COX-2 is actually where we get our, usefulness in analgesia, because it is primarily only expressed in inflammatory processes, and so you get less inflammation and less pain with inhibition of COX-2. Inhibition of COX-1 is actually associated with adverse drug effects because COX-1 is primarily expressed in the gastric mucosa and other places where you don't have inflammatory processes going on, and so you get increased risk of GI distress, ulcers, bleeds, things like that. So COX-2 selective agents were actually developed to try to bypass that adverse GI effect, but unfortunately, in recent years it's come to light that COX-2 agents are not without their own limitations. So that's kind of where this study fits into the knowledge base. So we know that COX-1 agents cause those GI effects, and COX-2 agents have actually been implicated in causing an increased risk of cardiovascular effects because it's thought to put patients in a prothrombotic state, because you actually get a relative increase in thromboxane from your cyclooxygenase enzyme, which is a prothrombotic mediator, and a relative decrease in prostaglandins, which cause dilation, so that actually makes them hypercoagulable and at an increased risk for cardiovascular events. So that's what this study sought to determine, was that what happens when patients, particularly our older patients, are using COX-2 selective agents for an extended period of time. So, in summary of the standard of care for arthritis today, non-pharm measures for osteoarthritis and rheumatoid arthritis are pretty similar. Kind of centers around patient education, weight loss if necessary, exercise as tolerated, and surgery in those really refractory cases. Pharmacologic therapy for osteoarthritis, a first-line agent is acetaminophen, with an alternative being topical or oral NSAIDs depending on the patient's site of joint pain and their comorbid conditions. Rheumatoid arthritis is a little different. NSAIDs are actually only used as an adjunctive therapy in that setting, only to control symptoms. But still, millions of people are using these drugs, so it's, important to evaluate the safety. So this particular trial was funded by Pfizer, and Pfizer actually participated in both the trial design and the data collection, which could be a source of bias and a limitation of the study, because generally you don't want people who would have a vested interest in the study turning out one way or another to be involved in data collection or anything like that. But Pfizer actually turned over all the data after it was collected to an independent research group, and that independent group is actually who performed the statistical analysis. So that would be a way to limit the potential bias, and that would be a strength of the study. Additionally, the authors had no limitation on their right to publish regardless of the outcome of the study. So as I'd mentioned, the cardiovascular safety of NSAIDs, specifically those COX-2 agents, have not been well demonstrated. And in fact, in 2004, a placebo-controlled trial found that patients taking rofecoxib, which is a COX-2 selective COX-2 selective NSAID, like celecoxib, was associated with increased cardiovascular events, adverse events. And that led to that drug actually being removed from the market. So following that study, another trial observed a smaller number of adverse cardiovascular events in patients taking celecoxib, but those particular patients who had the adverse effects were taking doses higher than approved. So because of that stipulation there, the FDA didn't take it off the market, but they wanted it studied at appropriate doses. They wanted the cardiovascular safety studied at appropriate doses, which is where this study comes into play. The researchers designed a study to answer the following question: is celecoxib non-inferior to naproxen or ibuprofen with regard to cardiovascular safety in patients with cardiovascular disease? The null hypothesis then is celecoxib is not equal to naproxen or ibuprofen with regard to cardiovascular safety in patients with cardiovascular disease. To answer that question, the researchers recruited over 24,000 patients, which would definitely be a strength of the study because that's a pretty large sample size. And they randomized all those patients into either a celecoxib treatment arm, naproxen treatment arm, or ibuprofen treatment arm with about 8,000 in each arm. So that'd be another strength that was, equally randomized. The average age was 63 years, with 64% being female, 75% being Caucasian, and 89% having osteoarthritis as opposed to rheumatoid arthritis, and 76% of patients fell into that primary prevention severe risk category. So groups were actually well matched at baseline. There were no statistically significant differences between those baseline characteristics. That would be a strength. Any potential differences down the road, couldn't be contributed to a difference at baseline, so that's a strength. And the sample demographics, although it seems skewed to a high proportion of female and Caucasian patients, it's actually pretty representative of those patients with osteoarthritis. That it's predominantly a disease of older white women. So that's actually a strength as well, the fact that it actually represents the patient population who would be affected.